from last week's presentation will be available to you probably not this week, but next week. So you'll have before the midterm, and it's just something that you can use to reflect on. Okay, so I'm just looking for, get this out of the way. I'm gonna move this up here. Okay, there we go. Now I can see better. So as you all know, have been studying for the past year, public health is a very broad field. Is concerned with ultimately protecting the health of entire populations and improving life expectancy. And so public health researchers and practitioners can play a key role in shifting away from the punitive paradigms that have been really entrenched within our criminal justice system or our criminal legal system. And so really there's a focus on abolishing the needs for carceral systems. So indeed, the harmful consequences of incarceration for individuals, their families, and communities, and the general public really demand a new focus that focuses on prevention. Preventive public health response is what we're really ultimately interested in. And great examples of this are provided in the American Public Health Association's statement on advancing public health interventions to address the harms of the carceral system. And they really carefully lay out several evidence-based strategies. And I was so lucky to receive some great commentary from the public health chief, the public health branch chief over at CDCR. She got to review some of the readings before she spoke to my class a couple of years ago. And she remarked on how radical, she thought it was. She thought it was awesome, radical in an awesome way, that the PHA had really laid out these strategies that are all evidence-based. They lay out carefully what they are, but also they provide the opposing arguments. So I should have made this required reading for today, but it is recommended reading. So I highly recommend it as a great resource for you all as you begin really sort of formalizing your thoughts and your ideas around solutions that are based in public health, really looking at public health interventions and solutions that are evidence-based to looking at policy that has really had so many unintended adverse consequences on public health. So really strong policy statements, and it makes me want to go back and get my degree in policy. But for instance, there are several strategies. There's about 5 of them that they lay out. And so they require investing in communities and alternatives to carceral punishment, but also looking at transformative justice. So they look at restorative justice. And so we're going to talk about that later on in the term, but they're really looking at transformative justice, which is kind of, really goes beyond just restoring, because you're like, what are you restoring? Something that was already broken and at the beginning was damaged. So then also decarceration, which is, I think, a really important focus out of the 5, to something to kind of highlight. So that includes policies and practices that really focus on initiatives to end cash bail. So that's one of the ways we can move towards decarceration, diverting people from the criminal justice system who have mental health issues or substance use disorders, moving them out of jails and prisons into community-based treatment, and then also employing community-based interventions to address the medical and social needs of people who have been harmed by the criminal legal system, and those reentering the community post incarceration. Also, they focus on decriminalizing substance use and homelessness, as well as sex work. So the last 2 evidence-based strategies are requiring investment in community based mental health care. So, we talked about how we had a system which was deinstitutionalized back in the it was actually kind of earlier in the 70s, and then during Ronald Reagan's administration, it was really sort of it just came all apart. There was no funding. There was this push to make everything community-based, but there was no funding to actually back that up. So it was really just like empty, hollow promise. And so looking at community-based mental health care is really, really important as one of those evidence-based strategies. So it's an extraordinary policy statement, and I definitely highly recommend it, to each of you to look at really informing how you might think about approaching policy change. So, of course, criminal justice policy change informed by public health principles. With public health, we often focus on the micro level. So disease prevention, education, interventions with at risk or hard to reach populations. But of course, we also want to focus on the macro level. So addressing the factors that contribute to the criminal legal system involvement and incarceration, reducing the impacts of incarceration on families and communities, reforming community justice policies informed by public health principles, and removing barriers to health for formerly incarcerated who enter or return to society. So really excited about going on to talk to you about the assignment. So I didn't get a chance to look at the discussion thread yet. I was working having conversations with our speaker today and focusing on today's lecture, but I did want to just go over the assignments for today and see if there's any questions for this term. So you've already sort of probably delved into the discussion thread that was due today or yesterday. And so that is part of the online asynchronous module. So you'll probably notice there's 3 different types of ways in which you can really sort of focus on the asynchronous module lectures and be able to share your thoughts and reflections and demonstrate your thoughts and what you're really kind of getting out of the readings as well. So those are all actually count towards your grade. 10% is the total amount. And so today we have a student-led discussion that Ashley is going to present. So that, feel free to pick any of the recommended or required course material. Doesn't have to specifically be for the week. It could be, you could jump around, anything you're interested in. And so that's worth 10% of your grade. And then we have the short answer questions and journaling assignment. And I think I made that's open now, so you can see that. So that's a conversation that we had with Dr. Ruben Miller a couple of years ago, and he provided these really great opportunities for students to think about public health, the intersection of criminal justice, and to really kind of look at different scenarios and exercise their writing through this journal assignment. So it's a kind of a fun interactive assignment where you can watch the video at the same time. The questions that he asks are listed in the Canvas course assignment. And so then we also have the fact sheet, and I'm not sure I have examples for you there, but I can provide them in Canvas. But yeah, last round, I saw some really great fact sheets from the students last spring, really exciting material. So you can think about these in terms of any policy or issue or public health program or problem or issue within the criminal justice system or even the carceral health system. So of course, fact sheets are all over the place. I was just at Berkeley Youth Alternatives, which is, we'll talk about that organization in a bit. I was just there yesterday, and they had lots of fact sheets up in there. It's so important that, the youth that they're serving, the population they're serving, that have this information. It's on STD, HIV testing. It's all about sexual health. And, this is the population that we are concerned with in this course. And so I do my best to bring in guest lecturers and really talk about the challenges and the issues that are facing today's youth, those who are at risk with promise, but those are also who've been in justice involved themselves. And so this was the population that one of our students is working with as an intern there. And she had developed a lot of fact sheets. She's supervising other interns, young people who are also creating them. And so this is an opportunity where you can persuade the audience to get on board with whatever policy change you're interested in pushing forward, but also policy issues within the correctional health system. So a lot of our classes will focus on, in the public health program, yeah, we're going to do a fact sheet, we're going to do this. I remember having to do that when I was in community health. And so, but this kind of has a different focus because your population or your audience could be impacted directly by the system, in the system. So it's a little bit different. So kind of a fun exercise. The midterm, I think I talked about this. So this is a short answer essay question. We'll have 2 different questions for you. And so I think you have a week to complete them. So it'll be opened up, I think, the 22nd, and then it'll close on the day before the next subsequent class. So you have a few days to do that. It's kind of like done over the weekend. And there's a rubric there for you to follow. Now you can see that it's probably open, and also what the requirements are, the length of the responses are all there as well. So then we have the policy analysis literature review, and I have a really great example that I have uploaded to Canvas, and I think there's another one that I wanted to upload. Is one from last semester, but it really kind of walks you through the process of doing an environmental scan that really pertains to the subject matter that involves the policy or the new policy, existing, or something you want to change, and really focusing on the background and just getting all the literature out there you can. And so some students have done it over like 2 to 3 pages. That's pretty much what the length of it is. And then ultimately it's going to help you with the proposal of your policy analysis. So it's all going to be for that. And that's a very short assignment. And then of course you'll have the presentation. So I hope I listed this all right. Yeah, let me just stop sharing because I want to make sure that you guys have the right slides up too for today. I did change the slides slightly, a little tiny bit, not that much. And I also could share with you to kind of go through Canvas too at the same time. How are you all finding the Canvas course so far? It's like pretty self-explanatory, pretty easy. Okay, so I'm going to go at assignments and make sure I have the right, because I did change my assignment slightly. So you can all see this. You all signed up for your discussion. And I think I sent a reminder that, everyone is going to have a chance to go have a second round. So, because we're a small class, so you get to do this twice. And we'll also sort of, get you prepared for presenting your presentation at the end. So yeah, so the proposal analysis is really sort of part of the presentation. So scratch the analysis part. It's kind of redundant if you already have the literature review done. But also I definitely wanted to look at the fact sheet. I wanted to see if there was any examples that I put in there. But you can see the wide range of potential topics for the fact sheets here too. But feel free to include something that's not here. We don't cover everything. So if there's something that's not listed, feel free to focus on that. Just want to see if there's any examples. So I will send you some examples of some really good ones that we've had in the past. So those aren't there. All right, so we'll stop share. But any questions about that so far, about those assignments? All right, great. That's good. It's to hear that it's cut it's very, it's clear. So I'm going to go ahead and close this out and close. And I want to make sure that you guys all have these. I can email them to you. That probably might be the fastest way. What do you guys? It's not that big of a file because they're slightly different. So I'm just going to do that. I don't know where. Bear with me. Okay. All right, so I'm just going to attach this and hopefully it will go through because it's kind of big. Okay, so it's preparing the slides. And Dr. Paczynski is going to actually send me her slides before her talk. She's super busy, as you can well imagine. So they should be coming right before her 2:15 talk. All right. I'll go ahead and make her lecture available now so you can see her bio, but just note her slides are going to be a little different. So she says she wanted to add something more to it. All right. Why is this not working? My computer is so slow. Okay, it's not responding. So I'm going to go back and share my slides again. Get back in here. My computer is super not happy. Nothing's responding. So bear with me. Hope I'm not crushing it. Okay. All right. All right, so they just revise slides. Hopefully this will go through it right now. So I'm just going to email you all that. And now, hopefully that will go through quickly. Can you all see this?
Yes, but we can also see your notes. Okay. Yeah, now we can just see the PowerPoint.
Okay, great. That was weird. All right, so we're on ground rules. So so in this course, as you can well imagine, we're going to discuss some sensitive topics. And students are always expected to both speak and listen respectfully to one another, as well as to the instructor. And so much of what we're going to be discussing and learning more about in this class is happening in real time in our country, and we're all experiencing everything in different ways as it relates to criminal justice reform, racial justice, and the pursuit of equal justice. And this is something that is doggedly persisting in terms of the hot topics, the most pressing civil and human rights issues of our time. I mean, sometimes, it can be a little overwhelming, especially for us if we're trying to capture, everything that's happening around public health and criminal justice. I know for me, it's just like overwhelming. It's exhausting. So I'm trying to keep my sort of finger on the pulse of anything. So I welcome ideas and information and news, and for you all to share that with us in class. But it's also important to know that while we're doing the work focusing on the health and mental health of people who are impacted by justice involvement, we also need to take a break and a pause for ourselves to acknowledge what's happening with us. And based on each other's lived experiences, some of the topics that we discuss may be personally triggering to some of us. So I just ask that we all assess our needs throughout this class. And if at any time you need to step away and take space for yourself throughout the term, I just want to urge us all to care for each other and ourselves. And also I want to acknowledge that we are all in different points in our journey to understanding how criminal justice impacts public health. And that's okay. We're all learning and evolving together. So of course, this is an environment in which we are all expected to treat one another with respect and maintain honesty and dignity. And also it's a safe space for us to share sensitive items in this class, things that we don't want to really have spoken about outside of class. So it will remain in this class. So everything here shared in class is confidential. As I mentioned, our lecture, and if I have any panel discussions or guest speakers, I'm going to record them. And but I tend not to record the student presentation. Sometimes I do, sometimes I don't, because I kind of want to remember and go back but I only use those for instructional and pedagogical reasons. But I just wanted to know if anyone had any recommendations for these ground rules. I will upload them to Canvas. No? Okay. Well, if these are great, I will go ahead and load those to Canvas. I think they're up now, but I'll make sure. So we all talked about a little bit about the public health field study. So we had questions about it last week, and I just wanted to kind of give you an idea of what that would look like. And so you all probably are aware it's the applied practice experience for students that, in which you complete them in a professional setting. And so it's also where you apply and integrate everything you've learned in the classroom, the knowledge and skills that you acquired during the didactic period into public health practice, really kind of confronting the real world situations that address public health challenges. So our program has developed a wide network of placement sites with partnering organizations that provide our students a variety of field study projects from which to gain valuable experience. Based on your public health interests, your skills, your experience, I will match you with sites and place you with them, and so that you can really work on a high quality learning experience. And the program Public Health Field Study also provides you opportunities for professional growth, developing and strengthening in public health skills, as well as, really looking at career options. So I'm going to just, like, full disclosure, I was talking with Dr. Paczynski today. She's like, yeah, I'm pretty much recruiting. So she's so excited to meet you, to really talk to you about the work that she does. So just some examples of what students do. So obviously this is a cumulative experience, and you're working over a 6-week block in a professional setting to get this field study completed. And so we have field study placement sites that include community-based organizations, nonprofit organizations, correctional health facilities. But of course, we have a vast network that we've started since 2005, and there's probably over 70 sites. And many of them are have been really there for the community health field study. But community health, obviously, that's, prison health is community health. So we've always had a prison site for our students, and it's namely been San Quentin from the very beginning. So there are lots of other types of sites. There's hospitals, there's clinics. There's a transitions clinic in Vallejo, which is where a lot of our students have worked with Dr. Ann Finkelstein. And so there's Drug Safe Solano, which is under the umbrella of Touro University. So that's been really great to kind of focus on substance use, mental health, and all the different programs, MAT, things like that. So just like a listing of our sites. So you all have this, and we have some in development. So Back to Start is actually a new nonprofit. It's just been around for a few months, maybe 6 months. It's started by the former chief of the Educational Partnerships Program at the California Correctional Health Care Services. And so she was really so instrumental in getting a lot of the placements really set up through the CDCR facilities. So San Quentin and CTF Soledad have been those main places for our students. And so without her support in the beginning, it's just so invaluable. And she has been a guest speaker in my course. She's also spoken to students and recorded, like we have a recording for students. You probably already saw that. I'm sure you met Dr. Jenny Espinoza. So she's actually one of the folks that talk about our track. She's a big supporter, big proponent. And so now she's got this new organization. She's no longer with CDCR. She has moved on. She received a big grant from the Robert Wood Johnson Foundation. And she's, this is kind of like her new career. And so she's working with people who are currently and formerly impacted by the justice system. And I think she goes into San Quentin. So it's a brand new site. We're just starting conversations. I might have a student for her like for next month. So, but Border Youth Tennis Exchange, that actually is a program that is run by, it actually serves as a field study site for global health. And, but now the director is working with youth at the Juvenile Detention Center in San Francisco. And so he's looking for a student. So we're going to see if that can work. Harmony Homes for Healing is actually a local organization that provides housing for people who are reentering into the community post-incarceration, as well as lots of other vulnerable populations, mothers, children, and Impact Justice, big company, or I wouldn't say company, but nonprofit that just got a huge grant for providing housing for the reentry population. They do lots of other things too. So we've been talking with them. The Inside Prison Project is specifically at San Quentin. They work with folks who are enrolled in different programming around really transformative justice, restorative justice. And it's the only place where there's a victim offender for the lack of a better word. It's actually the term they use. It's something we try not to use in this type of work, but that's what it's called. So it's the victim offender program that focuses on restorative justice. And so there is actually like contact and dialogue between victims and survivors and of crime and perpetrators who are currently incarcerated. So they do a lot of work there, but they do a lot of work with other organizations. They're kind of like the parent organizations to many others. So Billy Mizell, she's been a speaker in our class. She started out as an attorney who focused on post-conviction. So trying to reduce dodge the death sentence for many of her clients. So you'll meet her. She's a guest speaker. We recorded her last year, and she has a great story. So the Nevada Department of Corrections, that's for our students who are enrolled in the TUN DONPH program. So I'm working on that. There's reducing incarceration and recidivism, re-evolution. So that actually is a program that I was introduced to them by a student. So we'll have a student who found her own placement site, and she found this place, and it's based in Los Angeles. So I'm hoping, we're going to have a long, healthy, long-standing partnership. Reimagine Richmond, and it's wonderful. So they're doing a lot of great work. They're a grassroots movement. They're not a 501c or a nonprofit, but what they do is they try to provide technical assistance to groups who are really trying to mobilize, develop capacity building, participatory research, and so they're focused on research. So I'm really excited about them. San Francisco Public Health Defender's Office, I've got to call them back. So I'm very interested in finding out what their, focus, if they are interested in taking our students or if they want to be enrolled in our program. I'm not sure yet. So I have my hands in many, many pies. I'm trying to work on this. This is one of the organizations, Legal Services for Prisons with Children. We've had 2 students rotate there, and they're like a fantastic organization, legendary. We'll learn more about them, who they are. We focus on criminal justice reform. So you also have examples about the e-portfolios. So the e-portfolios, this is just kind of cool that we're talking about this now, because they're actually are student assignments or deliverables that are required for every student enrolled in the public health field study. So essentially it's a Google site. These sites provide links to these links here. You can click on these and you can check out what students have been doing. I love Google sites because they tend to not expire. Usually they're fine. Students can keep them forever, and then other prospective students and current students can check them out. They can use these links to find out what students have been doing at the different HECJ field study sites. So you can see there's quite a few. Let's see. So I got 3 slides of these. You can see other placement sites are Roots Community Health Center in Oakland, Drug State Solano, as I mentioned, La Clinica, Translations Network. Really excited. And so we also have Life Learning Academy Charter High School in San Francisco. I'm trying to reconnect with them for the fall. And so you can see here, we've got BYA. So I was there yesterday conducting my site visit for my student who's an intern there. And that was, it used to be a bakery. And so it's huge, it looks small. And so this is their logo that they had on the side of the building. So yeah, we've had quite a few, maybe 3 students now. And one student was so instrumental in her work there. She helped them secure $1 million grant. So that was huge for us. So our students now are working with 2 new preceptors. And I think one of the preceptors you'll meet, she'll come and speak to us on the subject of, I'm not sure, I might have to record her. I don't think that's a live class, but it's on the subject of reproductive rights for pregnant people in prisons, California prisons. So you get to watch a movie about that, which is earth-shaking for me. It came out in 2020. Has anybody heard of the movie Belly of the Beast? Oh, okay, you're in for a treat. It's pretty sad, but yeah, so I haven't actually watched the entire film yet because I just got access to it from my class, all my students. So I wanted to save it for you 3 students because I wanted you to be able to watch it as part of the class. So really excited about that. So, but one of the preceptors actually has been working on policy around reparations for women who were sterilized against their will without their knowledge in California prisons. So that's what the focus is of the movie Belly of the Beast. And so the speaker, Miss Mianta King, she has firsthand experience as someone who was wrongfully convicted and incarcerated for 18 years for a crime she did not commit and served time in the women's prison in California. So very, very interesting and just invaluable to have people with lived experience work with our students. So this is an example of one of the one of the student portfolios done at San Quentin, and it was focused on aging in prison. So you kind of see like what it looks like as a website. So that's what your typical e-portfolio would look like. This one was like probably not your typical one. It looks like super professional. So my TA and I were like, oh my gosh, this really looks like something, very professional. So one of our notes for that student's work. So other placement sites, obviously, I just wanted to let you know we've got Martha Benitez here. So she, like you all, she's DO in PH. She graduated in 2018, and she shared her reflections on her field study with La Clinica, Transitions Clinic here in Vallejo. And do you all know a little bit about the Transitions Clinic and what they do, the network of TCN? No, okay, that's cool. No, hey, they're an organization. They have onboarded 48 community-based primary care programs to the TCN model in 14 different states. So they're not in every state. They're not that well known, but they're well known for the work they do because they're really a model program that focuses on providing evidence-based strategies and solutions to improve the health of the reentry population. Specifically, there's a lot in California. There are 21 programs in California. So, but they have programs in New York, I think Rhode Island, Connecticut. So I'm trying to work with the other California sites so I can get more sites for you all. Because we have a wonderful resource in Vallejo, but I really want to expand this. And then, of course, I don't know if you all heard about our research labs. So it's a really active student participation. It really focuses on all these research projects here. It encompasses all of them. And it really is setting the tone for what, public health and criminal justice at the intersection really looks like in terms of having research that informs our teaching. And so participatory action research, PAR, is at the heart of this research. We believe that those closest to the problem should be provided with the tools and the resources needed to lead in its transformation. So having those voices at the center is so important. You can't have any change without people who are impacted directly. So looking at exoneration, you probably noticed, maybe not, there, you'll see later on the slides. So these slides, this organization, Exoneration, is, you'll learn more about them and you'll meet the executive director in our week on wrongful conviction. So we were so lucky to meet Obie Anthony, the founder of this organization, back in 2016, I think. So we've been working on research projects in collaboration with this national nonprofit. And so the California Health and Wellbeing Study, I don't know if you were able to watch the intro to the instructor video, but I talk about my experience and being the PI for that. And so, but yeah, and I mentioned it, I guess, day one of our first lecture. So that's really kind of where my research is at. And so we've also worked on an exploratory study on social support among the wrongfully convicted, as well as the coping mechanisms among the wrongfully convicted. So we've had students who have, not only those students who are in the program concentration, but alumni and students who are about to graduate. They've worked on some of our research projects, and they focus on the continuity of care, as well as exploratory studies on the impacts of reentry. So it's not just for those who are wrongfully convicted, but we had students who presented findings at the national conference. It's called ACCJH, it's the American Consortium of Correctional, I can never remember what it is, public health, correctional policy and health. So it was really, really great. We had, it's criminal justice health and in policy. But it's an academic consortium. And so they have this annual conference, and it's one of the only conferences nationally that is of its kind. It's amazing the work that they're doing. And they really don't focus a lot on wrongful conviction or even police violence. So it was amazing. We had students present on the Vallejo impact of police practices and Project COPE. this past April 13th and 14th in North Carolina in Raleigh, and extremely well done and very well received. I just don't think they have a lot of sessions that are on these topics. So there were people sitting on the floor, standing room only, and there were guests in the audience. They were hearing about Vallejo police and the history of all their wrongdoings, and what our focus was on healing and trying to promote healing among the community who have been impacted so much by police terror in Vallejo. So hey, I highly recommend ACCJH to you all, and to also get involved in any of the research that our faculty are working on in this lab. So more to come on that. So some examples of capstone projects. So we had a student who, actually, before we get into capstone, this is another project that a student was just working on her own. Another DO MPH student, developing mindfulness curriculum for formerly incarcerated people, working with La Clinica TC network site in Vallejo. So that was really great. She also did a photo voice project, and she presented at these two at ACCJH. So I remember going to that one. That was in Las Vegas. It was 2019 or 2018. It was before COVID. Oh yeah, 2019, the years there. So yeah, and then the photo voice one, she was able to finish that, and it was presented. So really, really exciting work for Catherine Koo, class of 2021. Going into the capstone. So just some ideas. If you're thinking about doing capstone, it's very exciting, a significant undertaking that gives students the opportunity to develop their analytical skills and to gain experience in a certain subject area that you like. And you would, if you were conducting a capstone, you would produce a substantial an original independently written manuscript that would focus on a significant public health problem. And so it's something that you would share and defend during an oral presentation. So hopefully you'll check out, or maybe you have already, some classmates have presented this past spring their capstones, and they were just amazing work, just really impressive work for students, and I think a large number of them were DO students. So really kind of cool. And then we had some joint degree students as well, and IMPH students. So yeah, if you ever hear of any coming up, they usually are held in the spring, sometimes in the fall. But if you can log on to Zoom for that, usually it's like from 10 to 12 or something like that. You can check out what people are doing. But there's just some examples. I saw last year, one of the DO MPH students who's in this concentration, she worked on a policy analysis looking at California counties' written policies under the 2018 law that requires county jails to develop and implement an infant and toddler breast milk feeding policy. And we also had a student who's in TUN's DO MPH program. She looked at analysis of syringe exchange programs in the carceral settings to reduce HIV and hepatitis C infections. So, this is harm reduction, a way to do that. And it's still something that many prisons and jails refuse to do. But she looked at the way they do it in Canada. I want to say Ontario. That was the focus. So a little bit more forward thinking in other countries when it comes to syringe exchange programs. Not something that's been wholly accepted in the US. And so, but it was really great that she was able to focus on this analysis of this policy in Canada. Right now, one of our students is working on a qualitative study. She's looking at comparing TUSD students who are enrolled in this concentration, like yourselves, and those who are not enrolled in this concentration. They were going to be in global health or community health. She's looking at provider attitudes towards patients with previous criminal legal system involvement. So really exciting for that work to come back. I think she's going to be presenting probably next spring. So look out for that one. And I just wanted to give you a little information about a study that we did. This was a, not IRB requirement. It was exempt from that. We did an in-class assessment. It's something that I still need to write a paper about. I have got like several papers to finish during my sabbatical, but this one focused on the perceived benefits of enrollment in this MPH concentration, which you all are enrolled in. And so we administered the survey during the last day of class, and we had 12 students who completed it, and they were all enrolled in the joint program for PA and PH, and they all 100% said they would, in this concentration, would have an impact on their clinical practice. And so you can see some of the examples here, what their qualitative responses were. And students were also asked to rate their understanding of their public health impacts of the criminal justice system before and after taking the course. So, we saw that they reported that they definitely had little knowledge before taking the course, and then of course over 90% have been reported a significant increase in their understanding. So this is some more of their feedback here. So very exciting. So then this is the next slide that we're going to go to, and it definitely kind of covers what we've read in Michelle Alexander's book, and I see that in your other class you're going to be reading a lot more of her book. So I'm so glad I just have chapter 1. So I hope that I've got the right slides up, because I'm looking here and I'm like, I'm going to stop share for a second. I'm going to make sure that I close all this out. So did you guys all get my email? I see.
Yeah, it went through.
After all that, so okay. Yeah, it's kind of big. Okay, so let's see. Did I change? Yeah, okay, so that should be there. All right, great. Yay, so let me open up the right one. All right. That's a nice pause. So, we got like 10 minutes before break. Oh my gosh, I don't know if I'm gonna get it all in. All right, well, I'm gonna do my best. So
Kelly, can I ask you a question about the field study?
yes, of course. Yes, of course.
I don't know if you know the specifics of this, and maybe I missed this part, but do you know when exactly for like the DOs, when in our schedule we do the field study? Like, is it during one of our green blocks, or is it during a
Okay, so yeah, it's a really good question. I'm glad you asked that. So both of our programs, COM, DO, and the public health program, always advise students who are enrolled concurrently in the dual degree program to complete the field study in the second half of year 4. So it's always in the spring of year 4. And I know it's like, really, that's the last semester before you walk, right? Before you graduate, go and do your residency. So, but that's when it's typically done. Now, it's not always done that way for every student, but the bulk of students schedule it during that time. So, like I have a student sort of just came out of the woodwork and is doing something this summer, in between the summer and the fall, which is kind of cool because they just happen to have that open. So I'm open to that. But the reason why they say to do it in the spring is because the fall you're busy auditioning. You got all your, audition rotations for matching. So that can be very, very busy time. So they don't want that to happen. And of course, the other recommendation for students is that they get it done, the field study, before match day. So that's always mid-March, right? So it's always like, it's like, I think next year it's on the 17th or something like that. Or so, but at the same time, they understand that that's not always possible. So, that can be kind of tricky. So you're looking at like early January, like January 2nd through, mid-March, right before, like that Friday before that match day on that Monday. So that's usually when it occurs. That's not always doable, but I have had students complete the field study on May 5th, which drives me crazy, because I want them to get everything done and conferred. Their degrees have to be conferred. So that's a little tricky. I'm not really excited about that timing. So, but it's, if necessary, we can't do anything about it, and so that was what 2 students did. One Farm student and one DO student, and they went to India together and they had this awesome experience, but they're not finished. So we're constantly like, are you done? Can you, and so they at COM, they're bugging me. They're like, are they done? I'm like, no, they're not done. So just to beware, try not to do it after April, so like April 1, that's kind of late. But we don't want folks to be too late. So hopefully that answers your questions, but that's typically when it's done. But I will say, if you can do it early in the summer because the summer typically you might not be doing anything. I mean, I don't know. If you start year 4 in the summer, what do you guys envision yourself doing?
Yeah, so I think my confusion is that essentially this is our last actual summer when we don't have anything going on for the DO program. So we don't have, except for the green blocks, we don't have, and there's like, because they do rotations in blocks, and there's some that are like, I think you get like 2 or something. So I didn't know if we were supposed to do, because like, I don't think we could do the work of the field study during an actual rotation. So I was just confused when we
you have to pick your rotations. Yeah, so basically what I try to do as a field study coordinator, I tell students a year ahead. I'm like, start planning your field study now, work with clinical education department to select your blocks. And so all your blocks are 4 weeks, right? And our block requirement for the field study is 6. So you have to grab 2 blocks that are free. You have to make sure. And so it's done. So students will just say, okay, I'm going to do my field study from February 15th to, whatever the 6 weeks is. So because they've actually designated those dates with the clinical education department. So they work it out with them, because of course your clinical rotations, are going to be, you're still going to have clinical rotations in the spring of your final year. But the idea is to get it planned early enough so that, you're planning it basically a year out so you can finish it. So all this information is actually in the student intranet. Has anybody ever been to the student intranet? Okay, so I'm going to just go to it now since we have 4 minutes before our break, and then I can just talk about the other lecture stuff if we have time later after our student-led discussion. So let's see, I'm going to share my screen. Well, first I got to open Box. So it's all sort of like it's like Box. So I get into it like in a different way. So I'm going to go into it now. Hopefully it's here. We'll open. Yes, it's opening. Cool. So you won't be getting the reminders from me because I'm actually I'm no longer going to be the field study coordinator after August 1. We have a new coordinator who I'm actually onboarding now. She's going to be full-time, I think, in July. So she's like basically 25 to 50%, over the next couple of months. Sorry, this is taking forever. I can't show it to you guys now. I don't know why. It's probably because I got too much open. Let me see. Yeah, I wish I could show it to you. But anyhow, it's a huge PowerPoint that I provided for each student degree program. So you would look for TUN or TUC DOMP's program, and that would be, just kind of like all the information for you. And it gives you the timetable, like when to start planning. So you're going to really kind of start year 3 planning, and early in year 3. And so I typically send out emails and I say, don't forget about the field study. Or you gotta schedule it with ClinEd. And then the process gets started. up till, and so, for my students who are in HECJ, those who are interested in like being at a CDCR site, I actually ask you a bit earlier for all your planning information. So essentially I asked you to apply for the field study. It's like a planning form, and you tell me what you're interested in, and you're able to like list 3 sites in order of the top preferred one. So 1 to 3 being, 1 being the highest. And then you send me your cover letter and your resume. And so at that point, I'm able then to make the match with the site. So typically that happens in October in the fall of year 1. I'm sorry, year 4. But it's, if you're interested in the site that's CDCR, I will ask for you to do it earlier, just because there's just not enough sites right now. There's only 2, and I'm pushing for more, actually, with the help of Dr. Baczynski. So does that make sense? Does that help answer your question? Like how you schedule? Yes, Ashley, you have a question.
Hey, Professor Kelly. All of this information, like a timeline and stuff, this is all already on the student intranet for us to access?
Yes.
Okay.
Yes. Yeah. If I had, like, let me just turn off my internet on my phone. And see if that would help me. I'm just going to turn off the Wi-Fi. Help me get into Box. It's just taking forever. Like, it's just churning and churning, and my computer is breathing really hard. You know what I mean? When your computer is really hard. So yeah, it's all there. So once we come back from the break, I'm going to stop recording. Maybe that will help with the bandwidth, and then I can show you all that. I'll just have it pulled up so you can see that. But we'll be joined. We can resume and reconvene in 15 minutes at 2:15. If you log on a couple of minutes earlier, and then we'll meet with Dr. Baczynski. And Eleanor, did that answer your question a bit?
Yeah, I mean, I'll look at the student internet. I think I'm less confused about the fact that we have to schedule that. I get that, but I think just like, because we are kind of told that we don't get to choose when our green blocks are, or like what our schedule is. So I don't know if maybe for MPH we do get to choose.
Yeah, the green blocks, like, it's all new to me, because nobody ever tells me that the color of the blocks. I'm like, oh, green blocks, I guess that means go and they're open. So I mean, I've never heard that terminology until now. But when I talked to Dr. Hendricks, she's just said, like, we try to just advise our students to work with clinical education to get their green blocks. I mean, just to start early. So I just put it out there where everybody, I need your dates. Like, I need specific dates. Sometimes I know they change, but very rarely. But when students get them, they're like usually set in stone. Then I can start planning on my ends to place you. So yeah, that's pretty much how it works. I think it's just like one thing is early planning, extremely early, and then just being aware that you have to get these dates. And then, yeah, you don't really have control over them. It's kind of tricky. Like for Susada, she would probably have more control with COP.
Yeah, I don't think we usually get 2 in a row. That's what I meant. If we could control that, I don't know if they'll if we can request to have them.
Yeah, because you have to put that request in. You say, I need 2 in a row. I need 6 weeks. So, and it's done all the time. It's done every year. Students get their blocks. So it's done.
Yeah.
It can be done. It's done every year.
Yeah, I think we just weren't told at the beginning of this, like when this, like the beginning of the whole program, like not on you, but like just at the beginning of the whole program, they're just like, yeah, and then there's this field study. And then I think as we learn more about what are like the fact that we don't have a second summer and what the rotations are going to be like, I think a lot of us were like, wait, when are we supposed to do the field study? But if they work with us, then that is,
yeah, they do. Yeah.
Okay.
Yeah, there's students who, and there's more information I can give you on like if you wanted to do it for a clinical distinct, well, not a clinical distinction, but a rotation, research rotation or elective rotation. Some students do that, and the public health field study satisfies both that course and our course. So
Okay.
that's something to think about as well.
Okay.
It's like
Cool.
a two for one. So
Great. Cool.
I
Thank
have a
you.
lot of students who do that.
Yeah.
You're welcome. All right, see you soon.
For got it. Some changes that are happening for the department that I think are really, really interesting. But I'll just go through some of the basics of the slide just to kind of give a little bit of context. Though I understand it is really incomplete, and it's so funny. I guess I gave this talk in January, and my perspective on the talk. Anyway, let's just keep moving, but we'll see how things go. Just quickly, we're going to go through some of the demographics. Just sort of like some of the kind of basics, the technical stuff. We're going to do a little on the history of healthcare in the California correctional system. It is a very incomplete history, and actually there's tons of stuff that's like, there's a lot of not great history. Not great's not even capturing it. There's a horrible history of healthcare in corrections that we would be a whole nother talk. So we won't really touch on any of that, but I do want to just kind of acknowledge it. We're going to spend a little bit more of our time on talking about culture change, which I think is like super fascinating. And then we may or may not get time to talk about prison healthcare delivery, instead of the unique aspects of providing care on the inside, because frankly, you guys, if you want to come for a tour, we can do a lot more talking about that. And it's not super exciting to do it in slides, kind of in my opinion. So just kind of rolling through then some of the basics about like, who are we talking about when we talk about, the population that's incarcerated in California Department of Corrections. And the current in-state prison population that I checked this morning that I think is already a little bit out of date, but it's roughly 96,000 people. I will just, and you can see here, there's a couple of these prisons that have closed. I actually have lost track. I think we might have 31 or 32 prisons. When I think I did this talk in January, it said 34, and I don't even know if that was right at the time. I still have not learned all of their names. The names involve C's for California, Corrections, Center, Colony. I don't know. We've used a lot of C words. Conservation. You can kind of see they're scattered. Where they are located is not by accident. For example, in the top, there's the map of California. The top left corner, Crescent City, Pelican Bay State Prison, which is a pretty notorious sort of supermax. It is not by, it's not a mistake that it was tucked in the furthest corner along the Lost Coast. That is absolutely by design. It turns out that's not been great in many ways, including staffing, especially for health. But a lot of these prisons are placed in towns that didn't have a lot of other things going on, kind of developed some prison industry around it. They end up often not being great for the towns themselves, not usually the windfall that the towns were kind of expecting. But it's tough when you're talking about prison closures in some ways, because it can kind of collapse the local economy. At the same time, there is need to close prisons because we need to do something else. And also, you really want to talk about it. In the future, some of these places, I think these prisons are probably, there's going to be challenges with climate change. That's also a whole nother talk, and there's tons of research that's being done around that. Starting to be some getting out there, I think, is also very interesting. Let me just double check my notes to see if there's anything else I needed to tell you. Oh, the other thing I wanted to say is that this is actually only a fraction of people that are under the department's sort of, maybe we'll just say surveillance, because they are jurisdiction, I guess is maybe the better word, but there's people that are on parole in sort of other kind of intermediate programs, so that in total it's 780. I looked it up this morning, that are under the jurisdiction. Just something also to keep in mind. And that California, I believe, is the second largest incarcerator, is that a word? Incarcerated population in any state in the US. So then if you think about that and pull back, well, actually, we'll get to that. Just generally, these are, this is pretty binary. We are now actually starting to have, they've changed the computer system so that people don't have to choose. We can actually, if people are identify as non-binary, the system is starting to be set up to account for that also. But generally, this is how the population breaks down. Demographics. This slide, I think, is particularly interesting in that you see the people that are 50 and older, and we're going to talk a little bit more about that going forward, because that number has increased significantly and will continue to. This is just a breakdown. It's a little blurry because I'd snipped it from a website page, but it's just going through the population, some characteristics of our population at San Quentin. So you see two columns on the right. One is SW, which is statewide, and SQ is San Quentin. This is breaking it down by the sort of our medical risk. So they have divided it 4 ways. So high risk priority 1, high risk priority 2, medium risk, and low risk. This is just based on just health characteristics. So for example, if you had a chronic disease, that would automatically put you into a medium risk category. And you can see San Quentin has a higher risk population than statewide. And this is definitely by design because we're located in the Bay Area. Our patients typically go to Marin Health Medical Center, which is just about an 8-minute drive by ambulance, which is really has been critical for us. They're great partners. We have a lot of specialists around here who are actively involved in the care of our patients as well and help us to provide excellent medical care. And this is in contrast with, other parts of the state that really are, again, because these prisons were built kind of far flung, so they tend not to have access to specialists. So if a person has a lot of medical conditions, that is, entered into the system and will help to determine where they can be incarcerated. So it means in part also that the medicine that's taking, that we're able to do here is really interesting. So this isn't just sort of your, standard like asthma, hypertension. We've got all kinds of stuff here that if you are, in medicine tends to be kind of the interesting stuff in addition to just the relationships that you develop with your patients. We have a really incredible mental health team here. It's about 100 mental health staff, and including 12 psychiatrists for a population. So our total population right now is actually about 4,100. There's a little lag in our numbers here. We have currently we've got 11 physicians. We should be at about 15. Which is some of our staffing hiccup that's going on right now because we'd had a rapid increase in our population. About 13% of our patients have some form of disability. 49% of our patients are 50 and older. And a lot of these, and our oldest patient is now 92, if you can imagine. And that's all. Again, that would be a whole nother talk to talk about why 92? Why is 92 in prison? And so it says men in the next column or the next not column, but whatever is the men and women's institutions. So truth be told, we have a lot of transgender patients and we have our first general population post-op transgender patient. Somebody I've worked very closely with on our inmate advisory council. And she recently completed her surgery and now is back and living here. So the M is really doesn't give the full picture. Specialized beds, I just realized that number is wrong. But that's kind of in a nutshell, some of the, demographics. And then I would just say, feel free to ask questions along the way. Because I'm just talking. Race and corrections. So such a, again, whole nother topic. Corrections is very interesting. We have not picked up standardized sort of demographic measures, which makes it kind of a pain if you're trying to sort of corroborate or compare, statistics inside this system with national or other states. And this here you have it broken down but this is not actually the statistics that the department collects. For example, Hispanic, we can unpack that, but to keep moving, actually the data that the department collects is, are you Cuban? Are you Mexican? Or are you Hispanic? So, and I'm like, what are those categories? And that's kind of a leftover from the correctional side. And the way that people sort of get marked into one category or another. And I will just say, you know, I say this as somebody who is half Mexican, half white, you know, always to find these, I guess they have other, but, you know, I'm like, really, this is not the face of California to be so kind of siloed in this way. But when people come into the system, how they are categorized along with all of their other demographics is sometimes determined by the person who is answering the question, so the incarcerated person, but sometimes it's just the officer who's just writing stuff down. So they might look at a person and be like, oh, I think you're white. And, you know, check that box and keep moving. So it's not, so the data is, what you see is not necessarily what you have in the house, which is just something to know about our numbers. And there's a lot more there. Anyway. I'm looking at the time and I got to keep moving because again, we could spend like an entire class on just talking about, you know, who constitutes, who is incarcerated and sort of the why, because the why is huge. And it's not, anyway, medical conditions and comorbidities for our population, a much higher burden of chronic illness. I'll talk a little bit more about that in another slide. Increased rates of infectious disease, Hep C, HIV, and STIs. Though I will say, this is traditionally more the case. We actually have, in the last number of years, had a tremendous push to, well, the goal, frankly, is if possible to eradicate Hep C, but our Hep C infection rates have plummeted due to very aggressive treatment and retreatment, in addition to MAT and sort of an increased effort in treating substance use disorders. So many people come into our system that have a history of substance abuse, which if you think about like who is being arrested, incarcerated, and kind of entering the criminal justice system, makes a lot of sense. And also that this is how culturally we have decided to deal with this issue with incarceration instead of outpatient or diverting treatment programs. But life expectancy for somebody who is incarcerated is 60 years on average. And this is compared to the US average of 77 years. And you know exactly why this is. There's no single reason for this, but we'll talk a little bit more in a few more slides about some of the potential reasons for this. Mental illness is a significant issue for incarcerated people. So just across the US. So these statistics are probably a little out of date as I'm looking at the report down in the corner. But, and again, this is in some ways, I think, no accident. We don't have the resources on the outside. This tends to be how we as a culture have decided to deal with people who have mental illness. I think there's a lot to be said also about the conditions under which we incarcerate people and what that does to mental health. So sometimes I think it's almost a chicken and egg game, but it's not always the healthiest place to be. Looking more specifically at diseases in our population, comparing it to the US, you can just see here, for some things, higher rates of certain diseases. Actually, you know, I should get, now that I think about it, I should get like the Hep C numbers are updated on this, because this is, I think these have changed, but just to kind of give you a sense of where we fall in comparison to the US population for our medical conditions. And then, yep, this is sort of the second half of this list. We see a lot of seizure disorders. This is typically related to, there's a lot of, and this won't surprise people, but there's a lot of trauma to the head that has happened to people prior to entering our system. Some of it happens while they're in our system that I think contributes to this. And valley fever, something that I had frankly not really thought too much about other than some esoteric stuff in medical school. but is a significant issue for us, in part because of all the places that the prisons have been built. And then HIV, we have very little untreated HIV in our system, and people tend to do incredibly well, in part because we've got a really robust treatment program. And when people come into our system, they have an opt-out for testing. So people get identified even if they have not. So a certain number of people actually get their diagnoses and coming into our system. This is old data, 2020. That was a really, really bad year. And COVID was our number one cause of death at that time. More typically, it's cardiovascular disease, cancer, and drug overdoses moved up quite a bit. The last few years had been doing better, but more recently, kind of like the rest of California, been struggling with, in particular, opiates, which is probably not a surprise to anybody. Just a little bit about San Quentin. It is the oldest prison in California, founded in 1851. Actually, I think it's supposed to be 52. The first inmates arrived by ship in the San Francisco Bay. They've been held maybe in, I guess the state had been relatively lawless. They would keep people on a ship, and there was a pier off of the San Quentin Point where people were housed, and then they would come onto the grounds during the day. There's an area that's still, you can still see it today, that was a quarry where people, where the incarcerated people would go and basically dig out the stone and build the prison. I think I said before that there's 32 facilities across the state now. Some of the older prisons include Folsom State Prison, which is pretty well known. And I think I'd mentioned that we're the second largest system in the US. That budget piece, that is for real. But in the picture on the right, you can just see, and in fact, I know that officer. We've got that old timey feel to us. And there's some pieces of it that are much older. Some of the original prison is preserved here. There's also a museum here that is sometimes open on Tuesdays that has really a really nice archive of some of the very earliest photos and records. It's kind of a remarkable place, though at the same time actually can be kind of painful to move through this museum and see some of this history so plainly. Medical has a very specific history in California, and I would not say it's a proud history. What's not reflected in these slides is frankly just a history of not just horrible medical care, but actually complete and total violation of rights for incarcerated people, including a physician that was here at San Quentin in, I think, the 1920s, who had a whole eugenics thing going. I mean, really, really egregious, truly remarkably bad. This kind of toggled, kind of moved forward over time, but there was historically this, it was hard to get people to work in here. And on the healthcare side, especially on the medical side, they would often take people who were not licensed. So you might have people working in the prisons, and this happened in other states, that's an orthopedist that had been, maybe had been drunk on the job and wasn't allowed to provide orthopedic care anymore after screwing up, for example, a surgery. And so instead they would work in a prison providing primary care that they were not trained to do. So you might have, OBGYN who's providing care to, in a men's prison, that kind of just sort of failure of the system. There was a federal law class action against California that started in 2001 by Plata and Co. That just alleged delays and failures to provide access to care, inadequate specialty care, insufficient staffing, and ADA violations, and was held up as being an Eighth Amendment violation. So this resulted in basically a cleanup and a huge grant. UCSF got that and came in, brought in people to just do consultations and what is it when you put rounding through the institutions just to sort of discovery rounds effectively. And when I came in 2007, it was a couple years after things had really started moving in this lawsuit. There was a lot of cleanup, and you could still feel that we're still kind of trying to push out some of the inadequately licensed medical staff. And while now, our providers, from exceptionally well educated, very intentional that they are here, but there is still, we still feel this reverberations of lack of trust that I think in part have some of the roots in this that's in front of us. Oh, okay. Well, anyway, we're in receivership now. I forgot about the second slide. Yeah, California settled, agreed to improve prison health care. They had 3 years to kind of get their stuff together, and they didn't quite do it. The standards were not met. And so then a federal receiver was appointed. And we're in the process now of kind of working ourselves out of that federal receivership. So that's where a federal judge has appointed a person to oversee the care. In this case, it is a lawyer, Clark Kelso. He's a lovely and thoughtful man, but just to really kind of provide that just federal oversight. San Quentin is no longer under the receivership, having been doing well enough to go back to corrections. And I think we will see the end of the receivership probably sometime in the next, I don't know, actually, I don't want to say, we're not even going to jinx it, but the state's moving out from under for sure. And actually, just as an aside, if you're thinking about like, well, how do you decide when a system is good enough? And, one of the things you can do is just, well, you want to kind of compare your stats to other systems. And one way to do that is to look at something called HEDIS scores, which if you ask me to break down what that stands for right now, I will not be able to. But all healthcare systems collect. So these are data on like what percentage of your population that you're caring for, has an A1C of over 9, kind of those sort of standard things you'd think in healthcare. And on most of these standard measurements, California Department of Corrections healthcare program hits it out of the ballpark, like numbers that exceed most other systems, including, Kaiser, Sutter, all of those major players, which I think is interesting to know. And also, when you're providing care on the inside is something that like, oh, you can actually get stuff done, which I think can feel good. What's to say here? We have more healthcare staff. Right now, we've got fantastic leadership and administration. We have this lovely building that if you come through here, you'll get to see. It looks like it's 3 stories. It's actually 5 because it's on a hill, but really made some improvements. When I started here, we had a building that was basically rat infested and leaky with a leaky roof. I mean, it was probably because I was young. I don't know how I would have tolerated those conditions. It was really remarkable when I got here. So a little bit about population and legislation. We had a history of severe overcrowding, and this is around the time of receivership. And one of the ways that makes it a lot easier to provide care for people is to have not so many people to care for. And this is also the part of understanding where corrections lies in sort of the bigger picture of California and how much corrections is in some ways, our failures are in so many ways like the state's failures. So failure to provide for, for our youth, for infants, for pregnant women, pregnant people, for all of these things. When we fail to do that, we, in corrections are sort of on the receiving or cleanup end in some ways. And then I'll also say that, there've been, there's some evidence also that as the department was, placed in this position to, a lot of pressure to decrease their population. Unfortunately, a lot of people left our system and did not have an adequate place to land. And there was an uptick in people that were homeless as they left our system. So while the numbers, it looks great to have the numbers go down. And certainly, it's better in some ways to have your freedom than to be in these conditions here. You have to understand that so their numbers don't show up on this, but they're going to, people's numbers are going to show up in another setting, in another system. Sometimes that's county jails. Here's a picture just when people talk about prison overcrowdings, this is what it looks like. So this is what was supposed to be a gym. and instead was crowded with these triple bunks. No, these are double bunks. There were some settings where you actually had triple bunks, if you can imagine. And this is how people were living. So literally no privacy, almost no place to store your stuff. And that this is what the department had, now you don't see this, but this is what it looked like. And providing care for people in this setting is particularly challenging. Increased admission rates to the state prisons during these years. Again, a whole nother talk. There's so much to talk about with corrections, but interestingly, that during this time, when you see increased admission rates to state prisons, you saw that the younger people, there was actually a decline in people of younger ages coming into the system, but the people that were older increased significantly, and that is not a typo. That is 308%. And there is some theories around this. The best that I've seen seems to say that these are people who early on in their life had contact with the criminal justice system, and that if you are in contact in your early years of your life, kind of when you're getting established, that it basically can result in a complete and total destabilization of a person's life. And so what you're seeing when people are age 55 and older, it being admitted is often being readmitted to our system, and that there are these cycles that if you are incarcerated or somehow involved in the criminal justice system at a young age, it's almost like you have to then do extra work to help to stabilize them, because you've removed them from, being able to really, I'm not even just talking about like retirement, but just, like all the development stuff that happens in your younger years, and what happens if you are instead dragged into a system where there can be exposure to violence, where you're not in control of your own life. Autonomy is not something that you have. But it is reverberating, and that the folks who are 55 and older had been swept up in this sort of like tough on crime era that had happened really in the 80s, and that we're still, while they may have changed the laws in a lot of ways, that we're still seeing that play out now. Of course you are. So, but that it's only more recently, I think, that this has been kind of all put together. We're going to just to talk a little bit about the challenges for our older justice involved persons. So inside the prison, there's, as we kind of talked about, accelerated aging, more accommodation needs. People who are older are certainly more vulnerable in many ways. And then particularly for people who are released, if you have no work history, if you have no retirement, if you've been incarcerated so many times that you have lost touch with any family, did not get to develop your own family, have ongoing health issues because of the nature of life while you're incarcerated, you can see that these are going to be significant challenges for people upon release. There's been a lot of thought and talk, and there's more to come certainly on this, for how do we help people then who, people should leave our system, and how can we help so that when they land back into communities, that they have the best chance of success as possible. So this is where I'm kind of pulling in some older slides or some newer slides. So this is a slide, just an informatics that I pulled from the National Institute of Healthcare Management. Hang on a hot. Sorry, somebody at my door. That just kind of gives some basic statistics, and I kind of like their graphics. But just thinking sort of nationally, so pulling outside of just California, but that there's almost 7 million people that are on probation in jail and prison, or on parole in the United States at any time. And that compared to individuals who have never been incarcerated, current and formerly incarcerated individuals have significantly higher rates of mental health conditions. I'm not sure what a mental condition is, chronic conditions, and communicable diseases. Again, in California, actually, our Hep C and HIV are incredibly well treated, but this is not the case in other systems. And then I think I don't mention it in other place, but it just also, you probably already are aware of just where California and the United States sits on a global scale in terms of who we incarcerate and how many people we incarcerate, and that it's usually not great to be kind of elbow to elbow with China and Russia when you're talking about, how many people we do incarcerate. There's plenty of stats that are out there, none of which are great, on the US's incarceration histories. And this is also something else that if we're talking about like thinking about like how do we take care of people on the inside then to help them be successful when they leave our system, but knowing that across the US, you know, these are not California specific conversations, but that you've got more than 600,000 individuals that are released from prisons every year. And I recently saw just earlier this week, kind of flipping through some stuff and saw a paper where somebody had posited that you need to think about this really as like a mass migration, that people are removed from their communities and that every year we are, you know, that the system is dumping out this many people. And that if you think about it more as a migration or mass migration, like we might think about it in a better way in terms of like, you know, allocating resources and just trying to make sense of this. But the truth is that we've done a lot to kind of have this happen in the shadows. You know, people are really sidelined from mainstream society, all of which has tremendous costs. But you do need to think also about like, who is this population that is coming back from the inside? People tend to have, you know, again, sort of higher rates of disease, significantly increased risk of death, particularly from substance use and opiates in particular. When people leave, a lot of challenges for people when they are out and back in society with employment, housing, healthcare. This is where conversations about ban the box and like what do you have to reveal, and discrimination can, you know, plenty of conversation there. Just in a little I don't know, gray or lavender box where it says on average, incarcerated adults are released from correctional facilities with more chronic medical problems than they had before admission. And I have to say, when I first read that, I got super prickly. You might say I was triggered. But I think that, you know, in some ways this is because I was like, oh, this is true. And I see this. And so here at San Quentin, we don't get people straight from county jail. We used to, but now people go to a couple other prisons when they're straight from county jail. And then some will come to San Quentin. And what I have seen is that often people were not getting healthcare prior to being incarcerated, and they will come to us after having been sort of quickly moved through the reception center prison. And while they'll come to us and their designation will be low risk, what my docs have kind of termed it is actually they're just pre-diagnosis. So, you know, when they get here and things kind of settle in, that's when we're really able to do the work and kind of and figure out like, you know, all right, what are your health issues? And you know, on the plus side, it means that they're being discovered and treated and managed. And our goal is always to help people kind of shore up their lives, because most of our patients are going to leave. And across the state, it's about 95% of people will return to the community. And so our docs really feel like it is their mission. Oh, wow, I'm really running over on time. Their mission to, you know, give people sort of the best chance health-wise when they get out there and have things under control. Is it okay? I'm running really, just stop paying attention to the time. I'm so sorry. Okay, all right, let's keep going because I had canceled my other meeting. So just quickly, it turns out that, you know, this might not surprise you, but I think that we can probably all agree that there are toxic stress might be a word that words that we could use to describe many carceral settings being filled with, and that, you know, the environment where some people live is also the environment where some people work. And so prison staff experience is absolutely affected by this as well. Correctional officers in a number of studies have been found to have significantly elevated rates of severe depression, suicide, domestic violence, substance use, kind of all of these things. And this is often the result. There's a study that shows that when they enter this correctional workforce, they do not have these problems. And this is specific. This is the repercussion of being in this environment. And this is starting to be in the conversation, and I'm here for it. It's like you can't fix something if you can't, you know, accurately identify what's going on. And while we see this, and I've known this because we get these announcements on the regular of correctional staff that have retired. And a few years later, we get an announcement of their death. And you're like, what is that? They were so young. So there is a nationwide movement called One Voice United, which is sort of this collection of correctional officer unions from across the state that are starting to kind of pull this information together and then sort of disseminate it back to people who are working in the institutions. The key then is to actually use this as sort of, to leverage this to be making changes on the inside. But that, and this information about the life expectancy of correctional officers is significantly shorter than somebody in the general public. And this is no small thing. This has also been something that has been going on for decades and has not been addressed. There's so much more to say on that. I just discovered this recently, but this CDC, or Centers for Disease Control and Prevention, has a definition of correctional health. And I don't know if I missed this like all these years, or if this is something that's relatively new. I literally had never seen this before. And I feel like I've spent a ton of time in CDC sites, maybe it's all COVID related. But here's the definition. Nothing is surprising, but I just want to point out, in light of what we were talking about, that correctional health also includes the health of the administrators and staff that work in the facilities. I love also that they have said correctional health includes the families and the communities of persons who are justice system involved, because you need to be thinking about this holistically. If we're going to be talking about how do you make changes and what is there to solve, you have to be thinking about when you remove somebody from a community, what that does to the community. When you put somebody back into the community, what ripples does that of effect does that have? So I thought this is just a really nice sort of holistic view that can kind of help to set intentions when we're talking about making changes. And if we're talking about making changes in California, they are actually on the way. So in April, the secretary, relatively new secretary of Department of Corrections, sent out this memo in addition with the receiver. So that's sort of the federal oversight on the healthcare side, basically calling for change and acknowledging that these prison environments can be unfavorable to the health and well-being of people who work in them and are sentenced to rehabilitate in them. And that we all need to, essentially the departments are committed to making the working and living environments better for all. Sort of three main pushes: improving the working environment, improving the health and well-being of people who work and live in prisons, and reducing recidivism. Worthy. 4 pillars, words that may not be familiar to people. I think, of course, you're going to understand, trauma-informed organization, peer support, normalization, and dynamic security, which are some of the kind of pillars or foundation for some of the changes that the department is proposing to make less familiar. I'm just going to quickly talk about these. Dynamic security is a way of providing this different kind of security. We're used to like static, which is, like the fences, sort of that like arcane, kind of castle, prison-y looking stuff. Those are your razor wire, electric fences, gun rails, that kind of stuff. Another kind of security within a prison is organizational. And this is just sort of like the usual sort of movement and flow of an institution. Everybody goes to chow now, everybody goes to bed now, so that you can have these sort of flows. And if anything is out of sync, you're going to see it. But dynamic security is essentially, I'll read the stuff that's in red, but it's this idea that behavior is shaped not by power and control, but by connection and responsibility. I pulled this from this book, Until We Reckon, which I super recommend. But it's a different way about thinking about security in corrections. And it's part of what I think is going to be, we'll see more of this. We're talking about corrections. This is not just happening in California. I was in Norway recently with people from Oregon and from Washington. There's other states that are looking at making these changes too. Another thing, sort of guide post for changes that need to happen in California that they've put out there is called normalization, which is to sort of make life inside the prison as close to normal, close to outside life as possible, so that when you leave the system, it is not so jarring, that you have been able to sort of practice having normal life on the inside, so that you can be more successful on the outside. And this may not seem like a big thing if you've got people who are incarcerated for short periods of time, but when you have people who have been incarcerated for 10, 20, 30, I was talking to somebody earlier today who's been incarcerated for 37 years, you need to know how to use an ATM before you leave our system. Here's an example of normalization. So we brought pickleball recently to the institution, and this is, got a lot of people kind of standing around watching, but this is actually our warden and chief deputy warden who's in the headband and wristbands that I bought him. It's such a such a champ, playing with a couple of our my patients, but incarcerated people. And we just all were instructed on how to play pickleball, and with the mixed teams, not in this instance, but often with mixed teams, which was just another example of like, you know what, let's we can shake things up here. Peer support, not, you know, people supporting people, not too much to say there. I love that the department is talking about becoming a trauma-informed, my own words I added, and responsive organization. This is really like, we should be always thinking about ensuring the physical and emotional safety of staff and incarcerated individuals. This is stuff that needs to be thought about when we're shaping policy, looking at procedures, but that this has to be a commitment. And so this is the department, you know, putting their nickel down on this. There's a lot more to come on this particular thing. And then just to quickly, before I wrap this up, just talking about San Quentin in particular has been, I was going to use the word targeted, but that seems super, sounds mean. And that's not what it is. But basically the governor in March announced historic transformation of San Quentin State Prison. Basically there's this initiative to reshape San Quentin and sort of rethink incarceration. Frankly, I'd like to think of it as kind of taking this place that already has a lot of things going for it and just making it just a lab for, you know, how can we make changes to this place that will potentially inform other prisons across the state. But, you know, per the governor, he's like, let San Quentin be a beacon of how incarceration should be done, if it has to be done, so that other people, you know, come to California, particularly to San Quentin, from around the world to learn from us because we're doing it so well, which is quite a project, but happy to see it. I can't complain. I mean, this is fantastic, and we're already on our way. I am on the advisory council for this, and I'm hoping that more than just a white paper that will generate, that we'll be able to make some pretty radical changes here. But it's, as far as I'm concerned, it's all on the table, which is pretty cool. And this is more or less my last slide, but just talking about how do you change a culture? You know, we've got this, we got a lot going on in here, and we have a lot that needs to change. And somebody at one of the, when we were in Norway on the first night, somebody from California had said, like, how do you eat an elephant? You know, if you're a mouse, you start at the front, you start at the back. And, you know, I had been really thinking about that. And I was like, what if we get 1,000 mice? And then it got gruesome. And I was like, okay, let's not think about that. But I think that the answer is really like, get as many people as you can to work on this. And then I also have to sort of temper my excitement with like, okay, also don't expect that everybody's going to be on board just because I am on board. You know, like we have to start thinking about like, it's one conversation at a time. It's hearts and minds, you know, as much as we can, but we'll pace ourselves and to make these kinds of changes, you know, this may take a decade or two really, but you know, you got to start someplace. So. And that's pretty much it. There's plenty, I guess, to say about educational partnership opportunities and corrections as a place to work or to visit, but I'm gonna kind of leave that. We'll let that go. Now I do the thing where I stop sharing. Do I? I don't know.
Oh.
How do I stop sharing?
So at the top or the bottom? Yeah, so it'll say stop the share. Oh my gosh, thank you so much, Dr. Paczynski. That was a lot. It was so, I love how you sort of like got a scalpel and you just kind of went into like the really, really meaty parts that were really, you know, that you really wanted to highlight that were, we really needed to hear. And I just thought it was so thorough. I just really appreciate your presentation. And thank you so much for focusing on a part of the carceral system that is often overlooked, the impacts of the system on the health of prison staff. It is something that I think I am remiss in this year talking about. I think we talked about it last year. So I am hoping that, you know, our students in this class are interested in talking about this, maybe discussing maybe potential policy proposals or solutions based on public health interventions. But it's such an interesting topic, and I thank you for bringing that to the light. And I want to now include it more into our conversation and our materials. So, in this, until we reckon, we have it. I don't know if you can see it, but it's part of our assigned reading. And so, I'm so glad you like this book. So.
Yeah. Oh my gosh. Oh no, I don't have it here. It's a great book, and so I've been making that recommendation and a bunch of others. I don't have it here, but one we're actually doing a statewide book group reading of What's Prison For, and then I'm hoping that I get to follow it up with Dr. Perry and Oprah's book on What Happened to You, which is it's a fantastic listen if you like audiobooks, because both Bruce Perry and Oprah are the narrators, but it's a fantastic book. Probably stuff that you kind of already know about development of the brain, trauma, how it affects things, and how you come back from that. But even with sort of like understanding that, having learned a lot of that stuff, sort of, or at least pieces of that, the way they put it together, and then with the stories, I think just helps explain so much. And talking with people who have read it, I think it helps people to kind of like maintain a position of compassion, especially if you have a patient that's in front of you that is like bringing all of that stuff into the room, and just to really like, how do you be there for that person? And then how do you help them? But a really excellent opening read, I think, also for some of the work that we do.
Oh, thank you for that. I've taken notes. Do you have time for maybe one or two questions from the student?
Yeah.
I know you have to go to another meeting. Okay.
Is there a way?
Hey, you guys.
Yeah, and then
Yeah,
I know I just had somebody knock at my door. Am I still sharing, or am I done?
I think you're sharing,
Okay, I don't
but
know.
maybe I can.
Take it back.
I don't know. Yeah, maybe if I do this, yeah, I go to them. I go remove those permissions. Okay, there we go. That fixed it.
Any questions? Even if the question is
Yes.
just, can you come and visit? The answer is yes. So no pressure too. It's not everybody's jam, so that's okay too.
I'm ready. Yeah, my question is, how should we go about setting up a visit to you? I would love to learn more.
Yeah, we absolutely. If you all wanted to come, we can just arrange it. I have to do gate clearances, but I'm happy to take a couple hours and kind of take you around, get a feel for the place for sure.
That would be so awesome. So we would email you to set that up?
Oh,
Yeah.
yes, I can actually set that up. Yeah, I can work with the gate clearance department.
Yep.
And and I'll make sure, I think I could probably use the same form. I can double check with Dr. Paczynski, but there's a form, and then I can sort of send it to you all in your drop boxes. And so it's protected, because it does require some sensitive personal information like your social security number. So like I had students do it in class last semester. So, we just had like everyone complete it, but some people weren't there. Like one person wasn't there and they had to put it in their drop box. Of course, we're all online in the summer, so we could probably do something like secure that way. And then I'll shred anything that I have, but
and everything on this side is secure, but we have to do some clearances, and there's just some, it's not too surprising. In fact, we had 3 people come in today, but the warden brought them in, but they were wearing jeans, and the warden was like, what? So, there's some, well, whatever.
Right.
We can figure this out. But for this summer, if there is time, or even in the fall, could find a couple hours, could do that. Yeah.
Great. Yeah, that's half the battle, is just finding the time that works for you 3 ladies, and Dr. Paczynski as well. So if that time matches her availability. So if we could do it in the summer, great. If not, I want to go because I'll be on sabbatical August 1. So but it might be a thing where I don't have to be there, but so we can figure
also
that out.
we could do it that way too. That would be okay. Yeah. Okay. Anything else? I would just say, the correctional officer health, there's not a lot of data. And one of the things I found, like there's a paper from, I think it was 81 or 82, where they lay out some of these basic statistics. And it's kind of, in 50 years, this has not changed. And so we knew things, well, I don't know, academics, I don't know who knew, but it was a national, I think it was DOJ or I think it was DOJ that had commissioned the paper. And so in some ways, like for 50 years, they've known that, yes, this is a toxic environment and it is doing things to the people inside. And, it's not popular to think about correctional officers because they, to be honest, like can and have been, perpetuators of some of, this really toxic environment. But if we are going to make change, like we really need to understand all of this, and you're going to bring people along to the change. People are going to buy into different pieces of the information and different messages. And I think that there's a lot of room. I know there's a lot of room to study that side of things because we're all in this collective community. If you're going to understand one slice, you really need to understand the other slices. And there's just not enough work done on this particular piece. So maybe just put that plug out there.
Wow.
And
yeah,
also I would
great.
say,
And then, maybe. Oh, go ahead. Sorry.
one of the other sort of interesting phenomena is that a lot of our officers come from the same communities as a lot of our incarcerated people. And so you actually have a number of officers that'll say, like, that could have been me, right? I just didn't get caught. Or if I had just taken a slightly different path, if I didn't have, this person advising me or whatever, that, a lot of times the people are pulled from the same communities. And so I think that actually can be a really compelling starting place for conversations about like making change. But it's just when you think sort of comprehensively about the system, it gives you kind of different pictures.
Really interesting. Yes, that's true. I think more and more we're hearing about higher rates of suicide amongst correctional officers, people who are working in the prisons or jails, and that has come up in a lot of conversations. And just kind of putting that spotlight on it, it's like, okay, so this is not a typical sort of group or subpopulation that sort of has maybe received some attention that deserved, well deserving, maybe just like, because like you said, they are seen as the perpetrators of like the adverse aspects of the system. And so it's like, oh, you hear the argument like, oh, but if you put it in that light, where it's a system nationally, not just some states are doing a better job, but where everybody's being affected by toxic stress, like it's affecting the people who are actually there to work and to work as staff. It's just not healthy for anybody. So
Yep.
It's very, very interesting.
Yep. Yeah. Okay, I see the time and I gotta
go.
go. But
You gotta go. Okay.
Right.
Thank you so much, Dr. Brzezinski. I really appreciate it. And I will
Thanks
follow
for
up with
hanging
you with my email that I promised you.
Okay.
And yes.
And any
Thank
questions or
you.
whatever, give me an email and then we'll be in touch. Okay.
Wonderful. Thank you so
Thank
much
you.
for
Thank
giving us
you.
time with us.
Thank you.
Wonderful.
Bye.
Bye-bye.